Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. In today's podcast, we interview George Davies, an expert in neurocognitive training, and I'm joined by my colleague Pradnya Gadkari at the Auckland Shoulder Clinic. So welcome, Pradnya, and great to have you join us for this session. And now on to the podcast. Hey, today it's my great pleasure to welcome Professor George Davies to the Glenohumeral Gurus podcast. George, welcome. I'm so excited to talk to you today. How are you doing?
I am doing great, and I'd like to thank you very much for the kind invitation. It's very humbling to have a chance to speak with you, particularly on shoulder problems.
Oh, how wonderful, isn't it?
You
And
have
I
an
wanted to
interest.
talk to you specifically today around the neurocognitive aspects of shoulder rehabilitation. I think there's such a lot we can learn from you, not only in this space. Can you just introduce for the audience a little bit about your physical therapy career? You were just outlining a little bit to me briefly offline, but could you explain how did all this start for you and this journey through? I mean, what an enormous contribution you've made.
Well, thank you very much for the kind words. Well, as usual, most people involved in sports medicine started out as athletes. So that was my big ambition. I wanted to be an athlete. I quickly found out I wasn't that good. So I tried to figure out a way that I could stay in sports. So through high school, I did all the high school sports and things like that, went to college and had had a previous knee injury and surgery and everything. So that limited some of my activity a long time ago. But at any rate, went to college and did gymnastics. Never did it in my life. At the end of 4 years, I was the team captain, which I thought was pretty cool. So when I was there, though, I also started working as a student athletic trainer 60 years ago this year. After I graduated from college, I actually then went and spent a tour of duty in the United States Marine Corps
Hmm.
for a couple of years. So I'm a United States Marine Corps veteran.
Right.
After that, I got out. I went back to college on a GA, graduate assistantship, as an assistant athletic trainer. And then I went on and became a head athletic trainer for a couple of years, which was great. But I also had a young family.
Right.
So during the day, I was teaching. The afternoon, I was covering the training room. And then I wanted to go home and have dinner with my kids. And I looked at my watch and I said, damn, I have to go back and cover another game tonight. That
Mm.
got old real quickly. So I
Yeah.
tried to figure out how I could stay in sports and to still control my time. So
Yeah.
I looked all over, rejected by many schools, but finally made it in and I went to Columbia University for physical therapy. And the rest is pretty much history. I left Columbia, then I went out to the University of Wisconsin La Crosse.
Yes.
I was there for 30 years. Jim Gould was my colleague there. We started JOSPT, and I was there. My goal was to be the longest faculty member ever in the University of Wisconsin system. However, unfortunately, after 32 years of marriage, my wife died from cancer.
Right.
And subsequently, I struggled. I
Yeah.
knew I had to move on or
Yeah.
continue to wallow in my self-pity.
Yeah.
So I moved on. So I then went to Georgia Southern for 20 years and taught there for 20 years in the physical therapy program and worked in the clinic. Then after 20 years, I said, nah, I need a change. So after that, I'm now down at the University of Texas, Rio Grande Valley. It's my 51st year of teaching physical therapy in the PT program. And I'm also the rehab specialist for the entire university, which is a Division I, 35,000 students with about 20 sports. And so I'm teaching and doing clinical practice, and we're doing research along with the topic that we're talking about today, some
Yeah.
of the neurocognitive types of things.
Yeah.
We
What do
were
you
at
think? I mean, you've got such an enormous history here, George. How do you think things have changed? This is not what we want to talk about, but I'm interested in your perspective of where we are now as physical therapists, physiotherapists, and where you think we might be heading. Do you know, like, how has that changed through your career? What have you seen is different? What's evolving? What's exciting for us?
One of my mantras is test, don't guess.
Yeah.
So, in other words, I think one of the main things that we've done is we've evolved from being more, I'm going to use the word technician oriented,
Mm-hmm.
more toward evidence-based practitioners,
Yeah.
where we do look at the research from both a testing as well as from a rehabilitation standpoint. And those that are really good physios, I think that we're very cognizant of that, and we're
Mm-hmm.
trying to do a better job implementing that into our clinical practices.
Mm.
Hence why we're looking at this whole concept of neurocognitive
Yeah.
approaches,
Yeah.
which again, I have to admit that frankly, for the first about 30 years of my career, I saw knees and more knees and more knees because that was popular in the 70s and the 80s and the 90s.
Yeah. Okay.
And I'm very serious. One day I was treating a patient with a shoulder problem, and I just looked at myself and I said, I don't know what the hell I'm doing.
Mm.
And I understood at that time, I did not understand the shoulder like I did the knee.
Yeah.
So consequently, for the last 20 years, a lot of our research and publications have been on the shoulder.
Yeah. Right.
Consequently, still keeping contact with the knee because
Mm.
ACLs are so common and all that.
Yeah.
We've learned over the last 10 years about the importance of neurocognitive testing, the neuroplasticity that happens with
Mm.
ACLs, and all the dramatic changes that are going on.
Yeah.
We run a Medline search right now. There's only about a handful of articles that really talk about the neurocognitive aspects in sports medicine
Mm.
type of injuries. And
Mm.
as a matter of fact, to my knowledge right now, because I've just presented at the isokinetic meeting and at ISAKOS, and I presented this material, that there's only two articles I'm aware of on neurocognitive specificity. In other words, there's an article by Shatira in
Mm-hmm.
Medicine and Science and Sports from 2022, and they've actually demonstrated that if somebody has shoulder instability, and this is where I think it's really important, that it specifically affects parts of the brain,
Yeah.
specifically the cerebellum and the frontal cortex. We also know there's certain exercises that are more conducive to enhancing those parts of the brain. Likewise, there's a study by Conboy, interestingly, in the Journal of Physiology a few years ago. They looked at rotator cuff tears. And interestingly, with rotator cuff tears, totally different using functional MRIs, the parts of the brain that are
Mm.
affected. So
Mm.
consequently, with those, it's the occipital lobe and the temporal lobes. So when I
Okay.
have patients who have those problems,
Yeah.
I'm focusing on exercises that are more conducive to enhancing those parts of the brain.
And how do
But
you, that's because it's something like we've talked previously about plyometrics and how you can adapt that into the upper limb. But I think specifically today we should stay with this neurocognitive processing because some of that I have then integrated into that late stage rehabilitation. Is that what you're doing? Like, are you the, or do you start trying to build that in, like with some of those low level plyometrics that we've talked about? Tell me your strategy for new. We've done, I want to talk to you specifically around testing, but in terms of rehabilitation, what are your thoughts there?
oh, we're starting it early, day one. I have patients maybe the couple of weeks out of surgery, and they may be doing, let's just say, submaximal multiple angle isometrics in a
Yeah,
safe range of motion to
yeah,
prevent AMI or arthrogenic muscle inhibition.
yeah.
Well, simultaneously with doing that, I might have my blaze pods set up and they're also tapping the blaze pods in different
Okay,
ways. So
okay.
we're already trying to connect the
Early.
dots It's not always just doing as we all know, it's the internal focus of attention.
Yeah.
We now know ecological validity or
Mm,
sports are
mm,
predicated more on the external focus of attention, being more aware of the environment and the
mm,
competitors and all that. So if
mm-hmm.
somebody's there and they're just kind of concentrating on activate the shoulder
Yes.
muscles, then that's an internal focus of attention. So we have them doing that, but simultaneously doing other things.
Do
It's the
you
same
think
way
at
with,
some point, no, sorry to interrupt you, but do you think
uh-huh.
at some point you need some internal focus before you layer up external focus, or
Oh,
you
absolutely. So they have to be able to do the submax multiple angle asymmetric activation first.
first?
As soon
Yes,
as they
okay.
get reasonably good at doing that and making sure they're doing that,
Yes.
then we add an extra
Then
component
you
and layer
layer that
it on
up.
top. Yes. Yeah, we don't overload them too quickly, no.
No,
But
that's okay. I think
I,
that's important for listeners to understand, isn't it? That first of all, you have to be able to do your base task well
yes, do the basics
before you
well.
then add
Absolutely.
in a layer of that those neurocognitive tasks, don't you?
But I think the what we've missed, at least learning, and again, we've got 10 years of data on the knee. I
Yeah.
think what we've missed is we wait too long to start
Yes.
layering on some of the neurocognitive interventions toward
Yes.
the kind of the terminal phases of rehab with the upper
Yes.
extremity. No, I make sure they obviously
Early.
you do the basics. You get rid of the pain as best you can. You start
Yes.
working on getting protected, safe motion. You work on getting submaximal muscle activation. So we do all the basic stuff. But as
First.
I said, in the past, I think we've all waited, just
Too
like with
long.
plyos. We can't start plyos early. We have to wait for longer periods of time. But
Mm.
that puts more stress and strain. But just doing the contralateral education or cross education overflow using the other arm to start doing some of the neurocognitive early on, I think there's no research yet,
No.
but it's going to be a matter of time.
Yeah, I hope so. I hope so. So for people, because we also have some blaze pods in the clinic that we'll talk to shortly, but in terms of people who don't have blaze pods, other ways that they could do neurocognitive training while they're doing their isometrics.
Absolutely. Just take colored papers,
Okay.
put colored papers down around somebody and call out the colors and
Yeah,
make them do
right.
that. Or
Yeah.
you could actually, again, even adding dual tasking, they're doing
Mm,
that, but you yell out a color, they can do that. Or if you don't even have that, you can do dual tasking of having them do the isometric exercise, then have them look at you and point. So they have to see you and then point
mm,
to a direction, which
mm.
is similar to sports. So if I'm a goalie in a soccer game, I'm not
Yeah,
only looking at the ball, but I'm looking at somebody coming down this wing. I'm looking at somebody over here. A
yeah.
defensive back in football, they're looking at the quarterback. They're looking at a screen being set up on one side. They're looking at a wide receiver going here. So as we know, sports are chaotic environments.
Mm,
So we've
mm.
been so structured for so long in
Yeah.
our rehab, we always have to do the basics and do the basics well.
Yes.
Yes. But then I think we've sort of missed the boat
Missed.
of
Yes.
starting to implement some of these things earlier on, which
Yes.
segues maybe into our testing.
Yes.
So several years ago, I was trying to follow the model from what we've learned on the knee.
Mm-hmm.
So we said, okay, we need to start doing some fancy testing. So we got these blaze pods. For those not familiar with it, all they are flashing lights. And you can set up a variety of random patterns with them and different things. So then we thought, though, with the upper extremity, there's two different variables. There's closed chain activities, wrestling, martial arts, climbing, gymnastics, side horse events, and there's overhead sports, your baseball, your softball, your tennis, your volleyball. So that way we had to figure out a couple of different ways of testing. So
Mm.
we started with both of those. So we started with closed kinetic chain testing, and we presented several years ago at our combined sections meeting some of the early closed chain testing with a single light as a reaction and
Yes.
then with multiple lights
Yes.
to try to add more stimulation
Yes.
replicating in sporting environments. The results were pretty good, moderate to substantial ICCs.
In terms of
Okay,
reliability, that was a
for
reliability study.
reliability. for
Yes.
test retest reliability.
For both the
Then we
single
did,
light and the multi-light.
yes, ma'am.
Yeah, okay.
Yep. Uh, that was from the closed kinetic chain
Yes.
upper extremity stability position. So they basically had to hit the lights as the lights would flash on.
Yes.
Then we said, okay, now how are we going to do it in the open chain? So
Yes.
everybody's familiar with the ASH test.
Yes.
Okay. So what we did is we took a dozen people, had them stand at the wall, 1.5 of their feet out. So it
Okay.
individualized it to the patient.
Mm-hmm.
And then we had them reach up in the flexion. We had a dozen people do that. We took the average of all the
Okay.
positions. So we did flexion in the center, scaption, abduction as per
Yes.
Ben Ashworth's ASH test.
Position
But I
test,
also
yes.
thought 90-90 was important. So we
Yes.
added that.
Okay.
So we have one blaze pod in the center for flexion. We have blaze pods up in each corner for scaption, on the sides for abduction, and
Yeah.
90-90.
Yeah.
And then again, we do single arm first, where we would have, say, the dominant or non-dominant or uninvolved involved. And we do single light, then we do multiple lights. Then
Yeah.
we do the second arm, same thing. So we can do at least a limb symmetry
Yeah.
index. It
And
gives
what have
us a
you, because
comparison.
we've recently finished a reliability study that's very similar based on some of your work. And we found better reliability with the single light than the
Yes,
multi-light.
right.
And our thinking, correct me if I'm wrong here, Pradnya, maybe you want to
Yeah,
jump in, but our thinking was maybe the multi-light was too much stimulation and too much cognitive overload to be a reliable test, whereas the single light was better.
I think in the other sort of what we did is like the kind of setup I guess Margie, we can perhaps explain him to him better because he can't see me. But we had it in sort of a circular setting, some similar to that. So we had
Hmm.
it sort of, you can imagine circle with 5 pods in the center pod.
Yes,
But
we
I
had a
think
center pod as well, George, so that we had one over top. So similarly, the limb symmetry, but also then, but both sides to look for all ranges of movement.
And when it was multi-light, because the light, they have to scan for a certain color and
Mm,
tap that color, and the color can be anywhere, you know. So we thought that this replicated more of the scenario in a sporting environment where, you know, they have to scan for a certain thing. They're not sure where it could be. And correct me if I'm wrong, because another thing I thought that perhaps the reliability is not that great is also because that pod that lights up that they have to tap, the distance can vary. So
mm,
sometimes, you know, the person
mm.
has to reach there or there, and that is not set up from trial to trial.
Yeah. What are your thoughts there,
What's,
George, in terms of setting that
yeah.
up to get, because we need a for to look at the testing. First of all, we need the testing to be reliable, don't we?
Yes, but our results on our initial testing, we did find moderate to substantial from about 0.6 up to about 0.8 for the ICCs for reliability. And as I said, we did single arm, dominant, non-dominant, and then we did limb symmetries, and then we did multi-lights.
Mm,
And we actually had one light at a time, but it went all over instead of just being
yes.
on the one side. And then we did again, where they had to do alternating patterns with single
Okay.
lights. And then we had alternating patterns with multiple lights, and they had to find the blue one. And even
Yeah.
though the reliability is less, and I agree with that, and our results show the same thing,
Yeah.
but
Okay.
still, I think that's closer to being ecologically valid,
Yes.
meaning it's replicating the real world situation.
Yes.
Because we don't just have a competitor who does one thing at a time and we
Yeah.
have to hit them.
Yes.
So I still think that's better. We have a colleague up at the University of Illinois actually did a validity study
Mm-hmm.
with 73 D1 athletes, and he actually demonstrated validity of doing those tests compared to other gold standard tests.
Like what?
So it's
Explain
just
the
an
validity
abstract at
bits.
this point.
Oh,
The other
okay.
thing the other thing that we've done, and to me, this is really where we need to head. Uh, yeah, that's all great having all these tests, but does it make any difference with somebody who has an injury?
Yeah.
So we actually had a paper at this year's CSM, one of my former residents, and it was a small sample, it was a pilot study just to get things going. But what we did is we took people that had instabilities in the shoulder, they were cleared for sports. We actually had motion capture on them. We had force plates and the blaze pods in front. So they
Right.
had to tap the blaze pod and go back to the force plates
Okay.
in a closed kinetic chain position.
Yeah.
We found is that the injured arm was slower, so the reaction time was
Mm.
slower. But
Mm.
to me, the most fascinating finding, similarly to what we have found in the knee, is when people are using force plates and they have like an ACL injury, they usually favor the involved side, so they stress shield it when they land so they don't
Yeah.
impact as much. We found the same findings, statistically significant differences. When they had to contact the force plates with their involved arm, they didn't have the rate of force development, which is the most important thing in sports. You don't
Yeah.
have a lot of time to generate force, but it has to be quick. So
Yeah.
we found the rate of force development was slower. And secondly, their forces were less because
When
they
they
were
load
favoring.
back on the force plate after touching the blaze pod, when they load back, the slow, well,
Yes.
less force, less time to, I mean, less time to peak torque or
Yes,
force there you're measuring, isn't it?
they took longer. So in other words, instead of hitting the force plate like that,
Mm,
they sort of more gingerly impacted
landing.
they were hesitant to load the extremity. And they were
Yeah.
all, at least 6 months out, cleared to sports and all that. So at any
Fascinating,
rate,
isn't it?
that
And you
to me
think
was the
then
most
about how
fascinating.
we are not actually rehabilitate. We think we've finished our rehabilitation process, and now we're
Yes.
starting to understand of the gaps that are remaining. So Pradnya and I have been working then on a similar, because also similar, our work is following similar channels, isn't it? And Pradnya is now testing with the blaze pods in this open chain. We see lots of instability in our clinic, and so we are measuring one side compared to the other in this instability population, looking to calculate or looking to see if there are differences first. We
Sure.
think there might be
Yeah.
differences, but we do need some research, like you were saying, to actually establish that some of these people who have had an injury are different in terms of their reaction time.
Yeah, absolutely. And we've done it closed chain. We haven't done it open chain yet. But
Okay.
next thing we have going on, we actually have a multi-center study going on because we want numbers.
Yeah.
So what we're doing is having different sites collecting numbers when doing the testing so we can then start stratifying patients. If
Yeah.
they've had an impingement or a subacromial pain syndrome, a SAPS, they'll go into this bucket. If they've had a cuff
Okay.
repair here, if they have an anterior instability here, they've had a labrum repair here. So
Yeah.
we'll get larger numbers
Yeah,
by
that will be
being able
great.
to do a multi-center study so we can stratify patients because I think there's even going to be differences within those
I think so
subsets.
too. That would
Just
be
like I
my,
said, with the
yeah.
Shatira and the Convoy studies,
Yeah.
they've shown different parts of the brain are affected with the different types of
Yeah.
injuries.
Isn't that
So,
interesting?
and
Do
I
you
think what you
think, yeah, it's going to be really interesting to see where we are in that space, eh? To see what that looks like.
I think you just nailed it, though. You just said a couple of minutes ago that we've all tested our patients using all of our clinical tests.
Mm,
And we didn't even realize the influence of these neurocognitive upper extremity tests. As
yeah.
I said, it's been going on in
In
the
the
lower
knee.
extremity knee for a while.
Yeah.
Dustin Grooms, who's an outstanding researcher from
Yeah.
Ohio University, actually has an MRI in his training room. So not only have they looked at brain scans with ACLs, but he's actually done open kinetic chain movements. He's
Mm,
done closed chain movements and looking at the differences of normals versus ACL patients
yeah.
with
Wow.
exercise, not only just as there a change, but even
Yes.
under the influence of exercise. So frankly, I've tried to follow a lot of the model of his
Yeah.
because
Us
we
too.
concurrently have the lower extremity going on.
That's,
We've
we're
done,
doing exactly the same. And I guess that leads us nicely because the thing, so I do want to talk to you about cognitive, that actual movement of your reaction time and the cognitive component of that. So when you have looked to distinguish reaction time into the cognitive processing versus the physical movement, you have looked to try and drill into reaction time a bit more, or you don't think that's an area we need to go to. Like when you see the light, how much of the processing time is your brain working that out, and how much of the time is the movement? You've thought
we
about
haven't
breaking
gotten,
that.
no, I think that's a critical question because that's also going to be, I wish I would have paid better attention when I went through my neuro classes back in
Yeah, me
school.
too.
But, but we have not gotten to that sophistication yet.
Yeah,
Ours is crude right now.
yeah.
Uh, what's the
So
reaction
hard to
time,
test
regardless
though,
of
isn't
whether it's
it?
here or the
Yeah,
physical movement? We haven't been able to distinguish that. I think it's going to take more. Frankly, we're just getting our lab
set
started at the
up.
new facility I'm
Yeah,
in.
and we
But
work in a clinical environment, and we had aspirations, didn't we, Pradnya, of setting up a
Yeah.
camera, then we'd be able to see the light change, then we'd be able to calculate time to movement and
Hmm.
then total time and really work that out. Do you have any comments about that, Pradnya? What your thoughts are?
I think, like you said, it's hard to like, and I've been following Dustin Groom's work as well. But because unless sort of you have an MRI or some sort of I guess it's very hard to capture while in movement. I mean, what we were
Mm,
thinking of to then video record them and then see their visual, like actual motor aspect of it and distinguish. It's not easy to do.
no. No. Do you have any thoughts, George,
what
on one versus the other? Because what I'm hearing from you in terms of the parts that make up reaction time, what I'm hearing from you in that closed kinetic chain, both that the physical movement is slower. So not only is there cognitive
yes.
processing differences, but the actual physical movement is also slower.
One of the faculty members I work with is a PhD, and he was in the military for 20 years, retired from there, has done a lot of research as well. And what we're probably going to do is use an eye tracking device as
Okay.
well. So what we're going to be able to maybe separate out somehow, and I'm not quite sure yet, but when they're looking, as all of a sudden that light comes on, we're going to be able to see how long it takes their vision to see that, because that's one
Yeah.
of the things with an injury we know in the lower extremity. When you lose the ACL, you lose the mechanoreceptors and the proprioception of the joint. So you become much more dependent on the vision. Just like one of your questions you had sent to me is stroboscopic glasses.
Yes.
I've used those in the lower extremity. I haven't used them in the upper extremity yet. But if we use this eye tracking, that may help add to the question you just said. It's going to take them how long to actually see it, and then maybe
Yeah.
going using video or something, we can go back and calculate the time, how long it takes them to physically react to it.
Yeah. But
That
also
may be
then what is
another
like
variable.
you and I and Pradnya are discussing the complexities of trying to analyze that in research. What does that mean for the clinician to try? Like, do you think that's ever going to be clinically possible? They're not going to have eye tracking devices, or do you
Right.
imagine that's where we're heading? What for the clinician here?
I think the most important thing for the clinicians are we need to at least become more aware
Mm,
of doing some type of neurocognitive testing, doing
yeah.
all of our traditional clinical testing. And I've published a ton of papers on that, as you have. It's not enough. We're
No.
learning, and we've learned from the knee. It's not enough. So even just taking blaze pods, though, and using very simple things like we've done,
Mm,
just looking, closed chain for, how many touches do they even have in a 15-second bout?
yeah.
Or the open chain, just doing limb symmetry, I think
Mm,
is really important.
mm.
Without getting involved in, is it really from the eye tracking? Is it cerebral? Is it
Yes.
mechanical from the motion? Most clinicians can't do that.
No.
Frankly, I'm sure I'm even at that level. I
Yeah.
just want to see, is there a difference?
Is there
And
a
if we can do
difference?
the limb symmetry index, I
Yeah.
think that would in turn help us say, okay, we've maybe completed all of our strength, power, endurance, plyos, all this stuff, but we
Mm.
still have this remaining factor that we
Mm.
have never addressed until the last several years.
Yeah. So
I
now I
think
want to
that's the
talk to
missing
you.
link.
Yeah, now I want to talk to you about neurocognitive alliance because my understanding is then we could look at so recently while I had a group, I was teaching on a course and I got them to do it like a seated medicine ball measured for distance and then a seated medicine ball in response to a stimulus so that they would have to wait until they saw a yellow ball drop and then they would push. But similarly, you could do for the blaze pods to see if
Sure.
that was my adaptation of the ACL light version.
Yeah.
Talk to us around neurocognitive alliance, what it is, why you think, because that's really what we're talking about, isn't it? The cognitive component that's missing.
Sure. Yeah. I guess typically when everything without the injuries, I think there's a lot of automaticity with things.
Mm.
In other words, if I'm in a sport and I don't have any injuries, then I'm going to, because I've trained so hard, there's what's called the automaticity
Yeah.
response. However, as we know, when the injury's there, it's going to cause that functional MRI has now well documented that. So consequently, what ends up happening, it takes us a greater span of time, even though it may be just milliseconds, to be able to react and then start to rely on our other capacities, whether it be visual, whether it be mechanical, whether it be physiologic. So I think that's the biggest thing is we've got to really start thinking of our conscious awareness, whether it's an automatic response without an injury,
Yeah.
but then it becomes more conscious, just like with the ACL. We
Yeah.
can't rely on knowing where our knee is if it's injured. So then we start looking at visual cues to know where the opponent is to be able to cut. So I just think it takes more mental effort with the reliance
Yes.
because you don't have the automatic response that we've had under normal conditions.
And
That's how
that
at least I understand the reliance concept.
Yeah, and that's
What do
how
you think?
we. That's how I understand it as well. To really strip away what is the cognitive component of that physical task, and also then how you might be compensating for that using
Yes.
other movements. And so I've really been thinking about that relationship between compensation and strategies, other strategies you might use, and then what you might see in that neurocognitive overlay when you dial it up and you make the exercise a lot more difficult for people. How do they then recruit? How do they move? So I've been thinking about the combination then of compensations and whether people compensate for the movement and then that concept of reliance and how that cognitive component, I guess.
Looking up, once again, I'm trying to piece together what are some of
Mm.
the better ways to rehab some of this stuff
Yeah,
and looking at a lot of research and whatever. I mean, as we know, a lot of the things basically you need to go into a lot more dual tasking.
yeah,
So that's what I'm talking about is instead of waiting to the latter stages of rehab, they're doing their multiple angle submaximal isometrics in a very safe position. But
yeah.
now we're starting to do other things as well.
Can you just
So
clarify for me? Because I've been reading around some of this dual tasking. Do you think it's just the cognitive component? Do you need to look different places, or is it actual movement? I need to do this, and also, what does the other task need to be? What's your thoughts on that? Do you hear
I
me?
don't know. I don't know, but I don't think it's an either or. I
Okay.
think it's a combination, and
Yeah.
that's where the concept of the dual tasking does come in. And I
Mm,
think the other thing is we talked about internal focus of attention versus external. Almost all sports are external focus of attention. But early on, because we hurt, because we have an injury, what are we doing? Oh, it's my body. I can't do this or whatever. Or when I'm trying to do something, I can't do it as well as I did before. So they're very internally
yeah.
focused. And I think we have to change that mode as well to get people being more aware of the external focus. So how do we do
Mm,
that? We sort
mm.
of force them to start doing other things.
Yeah.
Uh, and nothing dramatic, but I mean, just doing that. And I mean,
Mm,
simple things. So the person's there doing their isometrics, and I have the blaze pods going, and I say, okay,
Yeah.
hit the blue many times as you can with the, but we're also maybe creating cross education,
Yeah.
contralateral overflow response.
Yeah.
Because oftentimes I'll do a lot of rehab for the non-involved shoulder when I'm
Yeah.
rehabbing somebody early on when they're in a
Yeah,
splint
which
or
is
in
no,
a
which is
braces.
something different then, because I've done some stuff around, counting back from 100 and sevens or something ridiculous that requires quite a
Serial
lot
sevens.
of cognitive load, but you don't get the same contralateral overflow with that, do you? You just get a very busy brain looking in.
The difference, and a lot of people do use the serial sevens that you talked
Yes.
about, 100 count back. But to me, once again, no sports doing that.
No.
Nobody's out there on the pitch or on the football field and they're counting back as they're doing it. So I would come up with something different instead of having serial sevens. Maybe it's having them analyze what's the next sport, what's the next play that's going to come up.
Yeah,
So they're
okay.
getting the external focus of attention in a more realistic environment.
Yeah.
Because I've heard
Yeah.
everybody talk about this counting back by serial sevens, and
Yeah.
I don't agree with
I
that
love
at
your
all.
phrase around
Nobody does it.
ecological validity. I mean, my sevens have got none of
Yeah,
that, do they?
there you go.
So,
So
quick
I'm
question.
very much into the whole as practical and as you
Yes,
said, clinician oriented. I mean,
yes,
I don't have a lot of high techy stuff. We got the basic blaze pods and that's it.
yes.
Fortunately, using some university things, we can get a little bit more, but all my basic research has been with as fundamental as you can
Yeah.
get
Yeah, it's
because
important,
I
isn't
want to have
it?
it translatable to the practicing clinician.
Yeah.
Because to do all this fancy stuff, uh,
Yeah. Well,
but we
it's
can do some.
interesting at an academic level. It doesn't really have that much clinical overlay. Pradnya, did you have a question?
Yeah, so I mean, what I'm hearing, like with this, all this neurocognitive testing, and like we said, I think Maggie, we had that discussion earlier because I think the counting numbers is a cognitive task. And from what I'm hearing from you, George, is that if we want to have that ecological validity, then a visual distraction cue is the better way to do it, and could be on early on in the rehab as well. Is that correct? Is
Either that or
Oh.
instead of having them count serial sevens, nobody does that, have them trying to analyze based on the circumstances of the sporting environment, what's the next play?
Mm.
Right.
So in other words, I'm looking at a football, the American football. So they're third down and 7 yards to go. Okay, instead of counting serial sevens, I'm thinking through what are the best plays to gain
Yeah.
7 yards on their next play.
Yeah.
And it's the same thing. It's a cognitive load, but
Yes.
it's basically embedded in the activity or the sport. If
Yeah.
I'm out on the pitch and it's such and such and they're doing an attack, okay, who's the primary attacker? Who's the person who really stays out on the wing longer? So I'm trying to anticipate what those players are doing here rather than sitting there 100, 93, 80.
Yes.
I mean, to me, that has no relevance whatsoever. I think they should try to engage in the activity they're involved in and preempt, if you will, what the next play is going to be.
Yeah.
If somebody's in volleyball and they're going to serve, where are they going to serve into my court? Are they going to serve long? Are they going to serve short? Are they going to serve left? Are they going to serve right? That
Yeah.
to me engages them in the environment and it's an external focus of attention. It's
Yes.
engaging them here with something that's very practical
Yes.
rather than just counting
And so
numbers.
clinicians really need a little stockpile of just little
Mm.
prompts. It doesn't be short clips of video footing for their athletes to watch while they're doing the exercises. That's what you're saying, isn't it?
Or whatever the patient was involved in when they got injured.
Yeah.
I mean, most patients have a plethora of experience.
Mm.
So, I mean, you can even, if somebody's there doing their exercise, I may say, okay, it's using football, American football as the analogy. Okay, it's third down and 16. What are you going to do? And then they have to come up with it as they're doing their exercises. So they got to be
Yeah.
thinking of this next play, what they would decide. Plus, okay, do your isometrics now. Okay, but tell me, what is your answer? So it's
Yeah.
making them do
Much
both.
more
So it's
interactive.
dual tasking it's dual tasking. They have to do the isometric, but
Mm,
simultaneously, they're not internally focused just on that movement pattern,
yeah,
but they're also bringing in the neurocognitive reliance.
yeah,
That what they're doing is basically they need to use more mental effort to reactivate that muscle group from
yeah.
the injury based on what the MRI, functional MRI showed.
And so moving forward then for these, I mean, you've made some return to sport tests with working with Tim. I've then developed up some other return to sport tests, but how are we going to then see if we, so my idea of the seated medicine ball in response, that's one idea. I've played with using like a Baber, the ball abduction, external rotation. It's and trying to then replicate that with my blaze
Yep.
pods in that position. It
Yep.
seems it seems a bit more difficult because we've got the weighted task versus the unweighted task. Pradnya and I have kicked around ideas like that. What do you think in terms of where the testing is going to go in the upper limb? What are your thoughts there?
As I said, being realistic, in many clinics, they may not have blaze pods,
Yeah.
but everybody can go to a Walmart or whatever store and buy colored papers, put colored papers up on the wall, and they could call out numbers. So there, now they have to bring in the auditory,
Yes.
then they have to look for the color and then touch the color. So that gets multitasking.
Yes.
So, so something like that.
But how do we
But
decide then what to pass and fail from that? Like, how will we know, oh, yes, well, I can touch all these things, or how
yeah,
fast do I
well,
touch them? Where are we going there?
yeah, obviously, until we have even minimal descriptive normative data on your
Yeah,
population, we're not going to know.
no,
Uh, when the blaze pods, I think we're getting closer because there's
yeah,
a lot of research is being done with those at the present time.
yeah,
But my next iteration, what I'm doing next, which is our next study,
yeah.
is doing the exact same thing I just talked about, whether it's closed chain, open chain, all the variations. Then we're going to fatigue the subjects and we're going to
Okay.
repeat them
Yes,
because to me, that's the next missing element. Not
yes,
only is it our neurocognitive we're missing, but it's the neurocognitive at the ends of the games. Because when we're
yes,
really physically fatigued and neurocognitively fatigued from 60 minutes on the pitch,
yes.
that's where we're missing the link. So
That's
that's what our next
fantastic because
study is.
that's what I was thinking around some of those SARTs tests I made with Tim. You know, they're really difficult tests and they take a minute to complete, but we have normative data with rugby players that follows a set protocol. So and so then where we have that normative data, Pradnya, what we could do is test people before and test people
the fatigue.
Yeah.
after we've fatigued them.
Yeah, you could do it even if it were a way possible before practice, after practice. We're
Yeah.
going to modify it. We're going to do the testing in the lab. Then we're going to have them get on, say, an upper body ergometer, do a hit, high
Yeah.
intensity intervals, and then we're basically going to do them make them do the push-up release test for a couple of minutes. That
Yes.
will fatigue them, and then
Yes.
we're going to
And
repeat those tests right away.
yeah, right.
Uh,
When they're
we've
in that
actually
fatigue state.
We've
Because
actually
after,
we've done a similar study with our traditional testing. With our CKC test,
Yes.
we did where we basically did the test. Then we had people doing a landmine press.
Yes.
We fatigued them and they couldn't keep up with the metronome when they didn't do full range of motion or they compensated 3 consecutive reps. That was our operational definition of fatigue. We took
Yes.
them right back and had them do the CKC test. Then we did our seated single arm shot put test. We
Yes.
did the same thing. We had them do the single arm seated shot put, had them do single arm landmine presses till those criteria went back. And I know what the percent drops are in
Yeah.
normal testing. We
Yeah.
don't know what that is with these neurocognitive tests. So that's where we're headed next. That's my next two studies that we're doing,
Yeah,
upper
they
and lower.
sound fantastic. Really thinking about because that's also what happens clinically, isn't it? You know, these athletes going back to sport, they play into a fatigue state. How do we get them ready for that? It's
The
such a
majority of injuries
fascinating.
occur in the first 20 minutes of most games or
Mm,
at the very end of the
yeah,
games.
yeah.
So again, it's when
Almost
everybody's
regardless
like,
of the sport. Hey, regardless
yes,
of the
yes.
sport, you're either early up or at the end of your play.
So as a summary for a lot of the people that are
Yes,
driving to work,
exactly. We need to wrap this up.
once again, I think the take-home message is at least be aware of the importance of doing our traditional good functional testing that has good reliability and validity. But if you have the opportunity, I think we've learned enough from the lower extremity over the last decade that we also need to start including some of this neurocognitive testing for the upper extremity.
Yeah.
There's very little in the literature right now.
Yeah.
But again, I do think that we need to do something. And I think with everything that you guys are doing, some of the things that we're doing, I think we're heading in the right direction.
Yeah.
So
Oh, super exciting to talk to you, George. Thank you so much for your time. It's really,
you're very
it's just
welcome.
such a wealth of
Good.
information and such an exciting
Oh,
space for us to be
we could
working
talk
in.
forever, but
Couldn't we?
some of these people, some of the people on the call have to get to work.
Yeah, exactly. Hey, thanks very much.
But
Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.